Well, hi everyone. It's just to let you know I'm back just to start the new stream. So if you're coming into this to watch it on the recording or a catch up, then the teaching will start in approximately 13 minutes. So I'll put on the music, we'll get things going, and we'll see you for the teaching, which is starting, if you're watching it live, at 11 o'clock on the 15th of September 2023. Right. Hello, everyone. We're going to start because it's now 11:01. I am hoping that some of you have found the links and will be joining us very shortly. Just making sure everything's working at this end. I think it is. Just make sure it's, yeah. Just a hint to everybody, if you start YouTube and it's a little bit blurred, go down to the little cog and reset to the highest quality, because we are streaming at 1080p, 60 hertz. Or 60, is it 60 hertz or 63? I can't remember. 60 something. So do come in and join us. So we're going to talk today, again, part of the reason we have the last masterclass and this masterclass in block 33 is because there aren't a huge number of different types of drugs in mental health environments. So we use the space within this block to cover some of the generic stuff that we need to cover. So we're going to talk today about variations in drug action and effects. Just to remind you all that you can ask questions, come in and join us on the chat stream, which we're very keen for. I'm just going to float my chat out so I can see you all. Pop out the chat. There we go. Do come and ask questions. So let's get going. So not going to read through the learning outcomes because they're all on Blackboard, but we're going to talk a lot about what's called drug adherence, talk about concept of drug compliance, and about drug concordance, which some of these are slightly outdated terms, but you'll still find them in common clinical usage. So this is Yazzer, who's 25 years old and has type 1 diabetes. His diabetes is unfortunately poorly controlled on a combination of Tresiba insulin, 24 units daily, and Tresiba is a long-acting analog insulin, and Novorapid, and he takes that 1 unit for every 10 grams of carbohydrate that he eats at each mealtime. And Novorapid is a quick-acting analog insulin. His hemoglobin A1C is 92 millimoles per mole, which is pretty high. The non-diabetic range is less than 42. Normally, I would expect somebody to have good blood glucose control to have a hemoglobin A1C of about 50 to 55. So he tells you he doesn't want to be controlled by his diabetes, and he misses the odd insulin dose, odd misspelt there, odd insulin dose, and doesn't do many finger prick glucose tests. And he hasn't yet moved on to one of those fancy sensors. So as a doctor, how would this actually make you feel if you came across a patient? Here you are, you're prescribing medication, and Yazzer is basically saying, I'm not playing ball, even though this is life-preserving for him. If you've got type 1 diabetes and you don't take, if you stop your insulin, you can die within a matter of days. If you take it very poorly, but enough to keep you going, you're going to end up very early on with complications. And in my career as a diabetes doctor, I have seen people die of diabetic complications in their 20s when they only got diabetes when they were teenagers. So not taking your insulin can be a massive problem. So come in on the chat stream. I know a couple of you are there. It's good to see you back. Do tell us, how would it actually make you feel psychologically? What will, we're all human beings. If you prescribe a medicine and the patient doesn't take it, how do you feel? Are you of the mindset that says, well, they're the one with the problem, it's their trouble, I don't really mind, I've done my bit, I've prescribed the drug? Or are you going to be pulling your hair out and getting stressed and thinking, what am I going to do? This poor person's not taking the medicine. What do I do? I feel so bad. Where are you on that kind of spectrum? Where would you be, Richard?
Yes, I mean, so this situation almost exactly it comes up quite a bit in renal medicine, because as you can imagine, type 1 diabetics, they develop end-stage kidney disease, and then they come to you, and what's difficult is you're going to have a long-term relationship with them, whether you like it or not, and whether they like it or not, really, because yeah, they're either going to be coming for regular dialysis or they're going to be presenting every week or so in extremis and needing urgent dialysis. So one way or another, you're going to be getting to know them.
That's of course your patients with a chronic health condition, just like mine with diabetes.
Yeah,
We
yeah.
got a couple of comments
Uh,
there from Tealwer and from Sarah. So Tealwer's a bit uneasy, but it's their choice, and he wants to discuss the benefits and complications. Yeah, so I had to have a dialogue with the patient. Good. Sarah's saying annoyed, but maybe an underlying reason. Want to know the reasons for missing the dose. So again, exploring communication with the patient. And MR says, our role as doctors is to educate them on the consequences, but they must be fully informed. Yes, I think that concept of full, what we would call information disclosure, full informed information, because how can somebody who is a layperson make a judgment if they don't have all of the information? And of course, that information has to be given over to the patient in a language that they can understand. If they're not an English speaker, then you need to get an interpreter. And in that, I don't mean family, I mean a professional interpreter. And if they, I think it's an interesting one, isn't it? I mean, we all went to medical school with A grades and various other accolades, didn't we? To get into medical school, it's a highly selective process. But of course, if you live in some parts of the UK, obviously varies a little bit, but in some parts of the UK, there's quite a low reading age. I think the average reading age in Hull is somewhere between 8 and 11 years old.
Mm.
It depends whether you're reading the Independent, the Telegraph, the Times, or whether you're reading the Sunday Sport, the Sun, and the Mail on Sunday. These papers, if you read them, they're aimed at different reading ages. So you need to always speak to the patient at their own levels and language and with words they can understand, I think.
Yeah, like you've got to sometimes use different concepts to try and explain things, don't you? Different ways of trying to get the information across. Use it. I think sometimes using analogies that they might understand. That sometimes helps.
Absolutely.
Yeah, and just bearing in mind that it takes a long time, and you're not going to do it in one visit. You do it. Hopefully, you just try and keep that relationship going so that you're able to then have subsequent conversations.
I think there's no doubt that the doctor-patient relationship is critical in healthcare delivery, and of course, it's a great shame now that a lot of that has been lost with I think the loss in some ways of the identity within primary care of the family doctor, particularly with these GP surgeries now being run as companies, and actually often people will not see the same GP, and in fact they may only get a phone call these days post pandemic. So I think there's lots of work to be done to re-establish our roles as health providers. So anyway, don't get me going on that one. So we could talk about what's the definition of drug adherence, what's the definition of drug compliance, and what's the definition of drug concordance. So I'm not going to ask you the question to come in on that. I'm going to jump forward and sort of look at these. So I think these are important terms and concepts. So compliance is the extent to which a person takes his or her medication. We don't like this term anymore. I think that's fair to say, isn't it, Eleanor? Because emphasizes you will comply with taking this medication on the part of the doctor on a patient who is a passive recipient. And we now want to emphasize much more the partnership between the person taking the medication or seeking healthcare advice and the healthcare professional. Adherence, again, is a very pejorative term, I think, but is actually the extent to which patients follow medical advice. How much do they adhere? It sounds like sticking to something, doesn't it? It's are you doing what you're told? And then the much better term these days is concordance, which is where a healthcare professional and a healthcare receiver will create an agreed plan of treatment. In this case, we're talking about medications often, but this could be a non-pharmacological therapy. It could be discussing a lifestyle modification, for instance. And this takes into account the patient's wishes, their views. So, what are their concerns? What are their expectations? What are their feelings? You've got to build it all in. And as Richard said, it takes time. The reason why it's critically important is between a third and half of all prescribed medications are not taken as recommended. And then that may wonder why somebody's blood pressure isn't adequately controlled if they're not taking their antihypertensive drugs as they should be. So why might drug therapy adherence be poor? Let's have a look at this. When you actually ask people about what they're taking, particularly in the United Kingdom, and it's very much the case here, I think still, is I'm taking a little red one and I take a big white one. And sometimes I've got a blue one, but some other months it's white. So we have poor understanding. People don't really understand their medications. I think a lot of people with chronic illnesses also have medication holidays. You know, if you're taking a tablet for an asymptomatic condition like, say, blood pressure control, people might just have a weekend off, which isn't what we want. It's bad for them. People also may just not be very good at self-management. You know, they don't necessarily control a diet. If they can't control a diet, how can they also control a medication? The other thing you find sometimes, and this was interesting if you go back historically, when estrogens were first developed as medications, and this is particularly in North America, where all medicine basically was private. What you found was women would go and get their HRT or their estrogen preparation from one doctor, and then they would walk round the corner to the next surgery or next GP's office, as they call them in America, and get another dose of estrogen because they didn't tell the second one about the prescription from the first one, and were able to therefore boost up their estrogen levels because they felt better doing it. So actually hiding drugs prescribed by private doctors. People are scared of drugs. We spoke in the last one. Richard was asking the question about statins to me, and he was saying, you know, before we had the thing, we were offline and we were just chatting about why do lots of people not take their statin drugs? And of course, if you look at the effect of social media, we were discussing that. What's the effect of misinformation on social media? You know, are people more likely to believe TikTok than they are a drug information leaflet? Certainly, there's a lot of people seem to believe social media more than they believed government information regarding things like vaccines. And diseases where poor control doesn't produce symptoms, such as in diabetes or hypertension, then actually, because you're asymptomatic in some of these conditions, then you think you're fine, but actually you're amassing damage to end organs. And to be honest, changing lifestyle is remarkably difficult. And you also will find some people would rather take a herbal medication, which is self-administered, than take a prescription medication because their neighbor told them it was better. I mean, are these some of the things, Eleanor, that you've come across as a pharmacist?
Absolutely is, yes. Well, it's amazing what people trust in each other. It's a bit anecdotal, I know, but I remember a case where there was somebody who had a GTN patch for their angina, which they don't use that much these days, but there were. So that's what they used to treat their angina, for slow release glyceryl trinitrate. And their neighbour had a painful knee. And so this neighbour said, oh, well, I use these patches for pain. Why don't you try putting it on your knee? Oh, that's a good idea. So they put
the patch on their knee.
So they believe, you know, there's a belief in people that you trust.
Yeah, which I suppose goes back to what Prof. Hepburn was saying about continuity of care. Yeah, I think it's the main reason, to be honest, that I became a kidney doctor, is because of the continuity that you get in kidney medicine. But you do still occasionally get people who have a really good relationship with their GP.
Yeah.
I remember seeing a lady who, and I said, I think you should take dapagliflozin. And she said, okay. And I explained it all to her. And then at the end, I was thinking I'd write her a script. But then she said, no, you know, like basically, I don't know you very well, but I'm going to talk to my GP about it, and then he can prescribe it if we come to a shared agreement. So I was like, okay, fair enough. You know, it's quite unusual these days, but it's good if someone has that relationship.
Yeah, so I think that's some important points. So coming back to you on the chat stream then, how might you improve drug adherence? So thinking about some of those complex issues, what might be some of the tactics that you might use to improve drug adherence? What kind of things can be done? Come in on the chat stream, just with a couple of suggestions for us. Meantime, I'll be thinking about some answers myself. Yeah. So Lily's saying, explain why it's being prescribed, the benefits of taking it and the risks of not taking it. Yeah. Okay. Yeah. Absolutely. Yes. So I think it's having a dialogue, isn't it? And I think the other thing is it's also explaining, I think, side effects to people, common side effects. So if you say to somebody, these are the common side effects, but they're unlikely to be significant for you. Or this is what you do if you get them. Because one thing you do find is when somebody gets home, they got the patient information leaflet that comes with your medication. It has to be, legally, it has to be given to you when you get a medication. Even if you buy paracetamol at the supermarket, you have a patient information leaflet inside the box. People pull these out and read them, and then they see lots of side effects, and then say, oh, I'm not taking that. So, you know, explaining things beforehand, I think, is very important. Sarah's saying education using different methods of explaining analogies to make sure they understand risks and benefits. Yeah, these are all very sensible considerations. So if you look at sort of prescriber-orientated approaches, these are from what the prescriber could do. So continuity of care and a good doctor-patient relationship, which is why it's so upsetting when you find, you know, when you sometimes these days people go to see their GP and all they see is a locum doctor. It is good to see the same person, so one would hope that comes back into more common establishment now. You need to have an equal relationship, and I'm sure you're familiar with the concept that, you know, if you're the parent and you're talking down to the patient as a child, you're going to have a less positive outcome than if you're talking as a peer-to-peer level. So you need a coaching approach rather than a telling approach. You need to be able to set achievable goals. There's no point turning around to somebody and saying, you need to lose 5 stone of weight. You know, if you turn around and say, well, you know, why don't you try and lose a couple of pounds over the next couple of months? See how you get on. Achievable goals are important. Good communication at the right level with the patient and a non-judgmental way of checking. So don't be accusatory. You need to understand the patient. So a question of, you know, can you walk in the patient's shoes to some extent? So empathy, I think, is important here. If you look at medication-orientated approaches, you can use a number of different things. There are these 3 elements called medicines reconciliation, medicines optimization, and medication review. And these should be done by doctors, but are also frequently done by other members of the healthcare team. So it is very important that when you see somebody, you do a medication review. And in reality, if you think about it, when somebody gets admitted to hospital, the admitting doctor effectively does a medication review. I mean, Eleanor, from your perspective as a pharmacist, the things like medicines optimization is a big push from pharmacists as well as through medical staff.
Absolutely is, yes. I mean, they're just part of the whole team to ensure that they're taking the correct medicines, correct time, that the communication between primary and secondary care, there's all those sort of issues are very important.
So an example of medicines a very simple medicines optimization thing is if you take steroids before bed, they have an activating effect and they can keep you awake. So if you found the patient was taking their steroid dose at bedtime, you should ask them to take it in the morning. That way they won't have a poor sleep pattern and they're more likely to continue their medication. It's a simple optimization. And then medicines reconciliation, we all should be doing, shouldn't we?
Yeah, the optimization as well is that questioning, does a patient actually need to be on all the medications they're on? Just another
Well, people just end up carrying on with something even though it's having no real
Yes.
clinical benefit, or the original condition has now gone away. And medicine's reconciliation is just to make sure that what we think the patient is taking is actually what the patient is taking. And that's the same as what the GP thinks the patient's taking. So you can you do a reconciliation process, and that can be done by all members of the team, to be fair. And usually you need at least 2, if not better, 3 data sources.
Yeah, I was sort of covering both those in what I said, actually, because it kind of one rolls into the other to some extent.
Yeah, but I mean, I think it's important. I mean, I have had people coming into acute medicine with a bag of medicines brought out of the medicine cupboard, and in amongst it was the medication for the dog. Because your vet, if you've ever had a pet like a cat or dog, you'll know that your dog is called by your surname. So I have a cat, and when he goes to the vets, he's called Glenn Hepburn, because his name is Glenn, because he's named after Glenn from The Walking Dead. And so, you know, if you saw Glenn Hepburn, you might think that's a person's medication. And many of the medicines given to animals look exactly the same as the medications given to humans. So I have seen somebody prescribe their dog's medication because somebody didn't read the names. They just thought this bag all belonged to the one patient, because the paramedics had picked it up. I've also seen somebody prescribed their wife's medication. So these things can happen. So you need to reconcile.
Yeah, some of them are actually the same. We're a bit anecdotal, but anyway, it makes it a bit more relevant, I suppose. I've got a horse, and my horse was, she had a bit of obstructive airways disease, and she was prescribed prednisolone, but it was actually prednisolone that would be used in humans, so a big pack of prednisolone. The dose she was taking was
much higher.
100 tablets a day, but that was exactly the same pack that a human might have. So yeah.
And then other things you can do is you actually can combine products together. So you see this in some cases, things like Parkinson's disease. There are medications. There's one called Stalevo, which is its trade name, but it's made up of 4 different anti-Parkinsonian drugs. And you need to check and teach the right way of taking medications, particularly things like inhalers, and the use of things like calendar packs, and also pre-packed dispensing boxes, like often a thing called a Nomad system, made up, which has all the medicines given different time of day and per day, so that the patient just has to break open that bit of foil to take all the tablets for that day. That can help also with adherence. And then, of course, patient-orientated is all about emphasizing self-management, better understanding of the underlying disease, counseling for caregivers. So it's not just a case of talking to the patient. What about the caregivers who may be involved in administering the medication? And then peer groups, where you can actually use peer support from other people, particularly with a chronic health condition. So that can be really beneficial. So what kind of information should we give to a patient about medicines? Well, there's a whole range of different things, and you know, these different 5 dimensions can sometimes be used, but it's a complex system. How many people finish their antibiotic course these days? How many people take a medicine that has to be taken 4 times a day? My son recently was given flucloxacillin, and despite me badgering him, his wife badgering him, his mother badgering him, he still managed not to take flucloxacillin regularly 4 times a day. And he's supposed to be an intelligent young man in his 30s. So there you go. So 4 times a day medicines have a predicted failure rate in adherence. So I think some of the things you must tell a patient are: what is the medicine? Why are you giving it to them? When, how, and for how long are you going to take the medicine? What to do if you miss a dose? What about side effects, unwanted effects? What about precautions? So is this something that makes you drowsy for driving or using machinery? And what about problems if you're taking any other drugs, such as alcohol? So I think these are the kind of key things that should be spoken to with a patient, so you don't get any surprises. And what's really interesting is, I spoke earlier on about reading age. But health literacy, we always, I think, sometimes as doctors assume that people understand what we're saying. And actually, it's not uncommon. A doctor walks in, speaks to a patient, blah, 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 blah. They think they've done a fantastic job. They walk out. The patient then turns around to the nurse who was also standing there and says, what did he say? Or what did she say?
Yes.
I didn't understand any of that.
Mm.
And the doctor thinks they've done a good job, but they've spoken way over the patient. So it is important to understand literacy. And this is an interesting one. You can get somebody to read this. The first 3 words don't count because they're nice and simple. But in reality, if people cannot pronounce these words correctly, the chances are they don't know what they are. So, if you score less than 6 or less out of the 9 here, you don't count these first 3, then that suggests poor health literacy. And I think it's interesting, guys, when you all come into PBL and we start asking you to pronounce drug names, they are interesting. Do you remember, Richard, year 1 PBL, and students can't actually pronounce the names of the drugs? Well, after a bit of learning, you can. And of course, you could only use this for English speakers, but it is one of the tools you can use to assess health literacy. So don't assume your patient. I do remember one occasion, I had a gardener for many years, and on one occasion he came up to me and he said, can you help me with this? And it was, he'd got himself a new sat nav, and he had the sat nav in one hand and he had a leaflet in the other. And then he said, I can't set this up. Can you help me with it? And it then very quickly became clear that he was illiterate. I hadn't realized, I'd never realized that this man who was in his early 60s was actually illiterate. And he'd worked, he'd come round to the garden for about 5 years doing the garden. So it's interesting, we make assumptions about people without real substance.
Mm.
You can also use checklists. Here's an example of one checklist. I'm not suggesting you use these, but do you know the names of all your medicines? Do you know what the medicine is for? Do you know how to take them? Do you think you need all the medicines you are taking? Quite often, I think a lot of patients might take no to that one. So these kind of things, we don't often do them, but it would be interesting to study that.
Mm.
Okay, so I think that was just a little bit of a thing about just because you think you've prescribed something, don't assume it's being taken. I think that's fair comment, isn't it, Eleanor?
Absolutely fair comment.
I do remember, again, a little anecdotal case. I had a young girl, and well, it's in sort of late teens, early 20s when I knew her, and she was unfortunate. She had a combination of type 1 diabetes and Addison's. So she had adrenal insufficiency, and she used to always come into us, and she lived out on the coast at Withensea Way, and she always had a tan, and even in the winter she had a great tan, and therefore we knew she wasn't taking her hydrocortisone regularly, because if you don't take your hydrocortisone, you get an ACTH response because there's not enough steroid, and ACTH cross-reacts with melatonin. So if you inadequate cortisol, you get more ACTH, you get increasing tanning, and you can see it sometimes because you can look at the flexures and you've got darkened flexures. And then we sent her on a thing called a Daphne course for type 1 diabetes, which is about self-management of her diabetes, and she had a kind of an epiphany moment and the road to Damascus type effect. And suddenly she started taking her steroids, and she came back into the clinic 3 months later and she was as white as I was. And I said, you're taking your steroids now? She says, yes, I am. He said, that course for diabetes was great. So I realized I better take my medicine. So we actually could visually audit her adherence and compliance with her medication by her tan. This is an anecdote for you. So let's just talk now about another aspect of drugs, which is your drug actually working? What about the individual variability in response to drugs? Because we all assume you give a drug to somebody and it works the same in everybody. Well, the answer to that is no, it doesn't. So let's talk about Emily, who's a 14-year-old girl who is given codeine because she's got an irritable hip. So she's given some codeine for hip pain. So she has 15 milligrams of codeine, and the mother then notices that she's having trouble breathing. She's gasping and opening her mouth widely to kind of get air in. She's taken to the emergency department, where they give her a dose of naloxone, which relieves the symptoms. So the question is, why did Emily need naloxone when she was given 15 milligrams of codeine? I'm going to bring up the BNF. I'm going to actually bring up the BNF for children. And I'll bring it across in a second. And I'll show you the normal dose of codeine phosphate for an over 12-year-old. So bring over the BNF. I'm hoping this is going to work. Yep. So there's the dosage for codeine in a 12 to 17-year-old, 30 to 60 milligrams every 6 hours. Emily only had 15 milligrams. So what do we think went wrong with Emily? Can you guys think of any reason? What's happened that she's had this adverse reaction? You could call this an adverse drug reaction type A, augmented. Remember from the last masterclass? This is like an augmented adverse drug reaction. Any ideas? What do you guys think? Anybody want to hazard a suggestion? Too much opiate, yeah. But it was half the dose, so causing an overdose, yes. But why was it too much opiate? Let's have a look. So this is what the BNF has suggested. So in reality, this was a low dose. So you wouldn't have predicted that she would have a excess dose effect. So we all know that naloxone is a competitive antagonist, and it was useful to treat the effect. Have we checked her weight against the normal for that? Good thinking, Tilwa. Yeah, absolutely. You know, has she somebody actually, although she's that age, is she very, very small for her age or something? Yes. But in reality, that isn't the case here. So let's have a look at how codeine works as an opioid. So codeine is actually a prodrug, and it goes through demethylation by one of the cytochrome P450 enzymes called CYP2D6. And it's converted, about 15% of it on average is converted to morphine. And this is actually what causes the analgesia from codeine. So how would we identify the cause of the problem? Well, one of the things is, and you will have all heard from this from, I'm sure doing your A-levels or during phase 1, is that many enzymes have genetic polymorphisms. And CYP2D6 is a polymorphic or is an allelic gene. So one of the key problems is that you can have different activities of these enzymes. And one of the things you think about in the case of this particular cytochrome P450 enzyme is that you have some people who actually can metabolize greater amounts of the codeine. So did she make more morphine than would normally be predicted? So this different genetic makeup from perhaps the average person might have produced a very rapid metabolic pathway, hence metabolizing more of the prodrug to the active drug morphine. So what about the implications of being a CYP2D6 ultra rapid metabolizer? Well, in reality, like many enzymes, this CYP2D6 is polymorphic, but in this occasion, it actually has 90 known alleles. And if you're a rapid metabolizer, you can effectively get an overdose effect from a normal dose of codeine, or have more side effects. And here's just an example that, and I don't expect you to memorize this, it's just illustrative. But Emily, when she has genotyping done of a CYP2D6 diplotype, diplo means two, doesn't it? So that's the two different alleles. She actually has this coding. She's got a star 2A stroke star 10, 3N. So what does this actually mean? Well, at a genotypic level, what it means is she's actually got 3 alleles, 1 on one chromosome, 1 and 2 on the other chromosome. And they're made up of a combination of a 2A and a 10. So it could either be two 2As, or it could be 2 10s and 1 2A. And these are the type of alleles you get with their functional activity. So if you've got one of these middle ones here, you've got reduced enzymic function. If you're one of the ones in the bottom, it's non-functional. And then if it's wild type, which is what we classify as kind of normal, then you've got an activity of 1. So what do you actually get with these, the effects of these single nuclear polymorphisms on our diplotype? So if you kind of work it out, you can do these combinations, which we just spoke about. Have you got 2 2As and 1 10, or have you got 1 10 and 2 10s and 1 2A? So you can calculate the possibilities, but you end up with an increased activity level shown here. And it's because she's got 3 alleles, she's got a duplicate on one of her chromosomes, that can increase the activity level. And what you find is, if you look at sort of Western European population, this is the kind of breakdown you get for CYP2D6. So you get about 2% of the population who are ultra-rapid metabolizers, who've got very high activity of CYP2D6. You've got a small group who've got virtually no activity, who are poor metabolizers, and then you get the majority here, which is round about 90%, who are either what we call extensive or intermediate, where probably it doesn't have any clinical outcome effect. And this explains a couple of things, doesn't it? What it explains is, Emily, if she's an ultra-rapid metabolizer, could have made more morphine more quickly from a low dose of codeine than an average person. But it also explains why some people don't appear to respond to codeine, which I think, Richard, you've spoken about before, one of the earlier masterclasses. And this is the fact that some people simply say codeine doesn't work for me. So they're probably one of this 10% of people who is a poor metabolizer of, because they have virtually no function in their CYP2D6 isoenzyme. And what that means is codeine's useless for them. There's no value them taking codeine. So we can work out that with Emily's estimated activity level of between 2 to 2.5, that she is an ultra-rapid metabolizer. So you can also think about what would happen if you gave Emily codeine again. Well, I don't think we need to ask you in the chat stream, because if you give her more codeine, she's going to ultra-metabolize it, and she's going to end up with excess morphine. So it's a dangerous drug for her. So if you give her codeine again, she's going to become narcotized. And this is just an example here of the metabolic pathway for morphine. And what it's showing here, that this is one of the metabolic pathways. Not all of it's broken down, this pathway. That's where you get about 15% of it broken down to morphine. And then it's further broken down by the second step of metabolism into what may be non-active or residual active opioids. So one of the other scenarios you can get in this situation, which is of interest, is, and this was a paper from, originally from, I think it was Canada. Yeah, Ontario, that's it, Canada. And this was about pharmacogenetics of morphine poisoning in a breastfed neonate of a codeine prescribed mother. So in this particular case, what happened was the mother had a section, I think, and was given codeine post-section. And she was breastfeeding the child, and she was an ultra-rapid metabolizer. So she converted more codeine to morphine than would have been normal. And the morphine goes into the breast milk, and the baby ended up narcotized and actually died of morphine poisoning in this case, because the mother was an ultra-rapid metabolizer of codeine. And this is just the family history showing the different genetic makeups of the different individuals. Here's the index child that died, the young boy, died at 12 days from opioid poisoning, and the child wasn't a rapid metabolizer, but the mother was, and you could track it back and showing again the genetic breakdown between family members. So the original ultra rapid metabolizing element here, the 2AX, was being carried down through the maternal line here.
How often do they test people, David, or is it sort of as a result of an incident like this and like the Emily's situation?
Well, I think what's happened in the if we go to the BNF, what's happened to make it safer in the UK is that actually, if you look at codeine, here's codeine phosphate in the children's BNF, it doesn't have an indication for anybody less than 12. So rather than routinely testing for these genotypes, which was expensive for a very small number of people, what actually the decision was taken that nobody who is below the age of 12 should receive codeine, because younger children are more sensitive to these kind of effects. So the safety solution in the UK is codeine can't be prescribed for anybody under the age of 12. So that's how they made it safer there. But this instance with the mother, I mean, it was a rare enough instance that, of course, it got published, didn't it? But so it would be unusual. I mean, in an adult, ultra rapid metabolism might just mean you get more side effects. So you might find somebody that's given a relatively moderate dose of codeine and says it just wrecks my day. I just end up lying on the couch sleeping all the time. And that might be the adverse effect from being an ultra rapid metabolizer. And what they might then do is say, I don't want that drug anymore. So they actually automatically take themselves out from that scenario. But these kind of effects are more sensitive in children, of course, and also potentially in the elderly. But by the time you're elderly, you've probably taken a drug at one point and decided, I never want to take that again. And then the other group of people who said that they are the poor metabolizers, they basically at that point probably say, it doesn't work for me, I'll try something else. So they take another opiate instead. Okay, so codeine isn't the only drug that's metabolized by or affected by genetic polymorphism. And can you think of any others? You may or may not be able to think of any others. Do you know any other opioids that are prodrugs? Can you think of? Maybe you do, I don't know, maybe. Eleanor, can you think of any other opioids that are prodrugs? Oxycodone?
I was going to say oxycodone, yeah. Tramadol, is tramadol?
Yep, tramadol, yeah. So well done, Sarah. Yeah, Tealwa said tramadol, yeah. Yeah, so the common ones are hydrocodone, oxycodone, which is increasingly popular. I think renal physicians like oxycodone, don't they, Richard? Because it's not as it's partial. Is it not partially hepatically metabolized?
Yeah, that's right. Yeah, so it's what we'd say was like an amber drug. You still have to be careful, but it's not a red drug like codeine, which is very heavily renally excreted.
Yeah. So let's have a look at these. Let's look at tramadol as an example. Please don't memorize this slide. Do not memorize this slide. But basically what it's to show you is that, here's tramadol. Tramadol actually is a prodrug, and it's extensively metabolized by a number of different pathways. But one of the pathways is CYP2D6 up here. And again, it's oxidated to desmethyl tramadol. Don't remember that name. But this is predominantly the active metabolite, which is causing the binding to the mu receptor. So again, if you're an ultra-rapid metabolizer of CYP2D6, then you're going to also find excess effect from tramadol as well. But interestingly, I don't think that's... let's have a look in the BNF. You guys have a look at that diagram for a minute, see if you can understand any of it.
Yeah, because we did this for dihydrocodone, didn't we? And they didn't have any information for that one.
But if you look at the BNF, for tramadol, again, there's no indication for under 12-year-olds. So they've taken the same safety step with tramadol in children, is saying you should not be giving it to children under the age of 12 because it's got the same problem with CYP2D6 ultra rapid metabolism. So there you go. That's just a bit of interest for you. So these are showing you that these relatively common drugs are not going to act the same in every person. So there we go. So with tramadol, you get increased analgesia. So Tila, you said, would you never give opiates under 12? What's the best choice? Right, okay. All right, well, let's have a look. You've asked a good question. So these are prodrugs. So with ultra-rapid metabolism, they're prodrugs. So you make more of the actual active molecule, which is what is then having the clinical effect. So in this situation, why morphine is the active metabolite of codeine. So why don't we just give morphine? So let's have a look at morphine in the children's BNF. So bring up the MEF. Pardon me. So I'm going to come down and go to indications and dosage. So actually, we can give morphine to a neonate. Because morphine is not a prodrug, it's the active drug, it's not going to be influenced by this ultra-rapid metabolizer problem that codeine is affected by. So the way of getting past this issue is just to use the actual active component as the drug itself. So if you had a child, say, with a broken, fractured femur or something, then you could give that child, say that was a 2-year-old, you could give 200 micrograms per kilogram every 4 hours. And a 2-year-old probably would be about 10 kilos, thereabouts, maybe 12 kilos, a 2-year-old. So, you could give 400, 500 micrograms every 4 hours of morphine quite safely in that situation. Hope that answers the question, Tilwa. But so, yes, so by knowing what happens to the drug and knowing its metabolic pathway, you can choose a safer drug. Come back to the active seat. So let's move on and talk about Jim. This is Jim. He's 55 years old and he's admitted with a sore throat and lethargy. And his bloods are done and it shows a pancytopenia. So all his cells are down, his red cells, his white cells, his platelets, everything's down. And 8 weeks earlier, he had commenced on azathioprine for Crohn's colitis because he'd been taking mesalazine and prednisolone. And that wasn't working, so he had azathioprine added. So rather than increasing the steroids further, which would have adverse clinical effects, azathioprine was added as a non-immunosuppressant, but also as a steroid-sparing agent to allow you to have greater immunosuppression without adverse steroid effect. So why do we think Jim has developed pancytopenia? Anybody got any ideas in the chat? Why do we think Jim's developed pancytopenia? Which of these drugs potentially do you know of? Because we've done gastro. Which of these could cause pancytopenia? Any ideas? There's kind of a hint in the history. I'm guessing it's the azathioprine. Yeah, oh, that's a good. Yeah, azathioprine, good stuff. So it is quite a low dose of azathioprine. So why do we think he might have developed bone marrow toxicity? Well, again, azathioprine is what we call a prodrug. So this is azathioprine metabolism. And azathioprine is metabolized to this particular molecule called 6-mercaptopurine. And 6-mercaptopurine is the active form, which 6-mercaptopurine actually was originally developed as a drug itself as an anti-cancer drug. So this will suppress, it's a as 6-mercaptopurine suggests, it's a purine analog. So it interferes with DNA repair and replication. So it will prevent the generation of rapidly turning over cells, such as in the bone marrow. So you get bone marrow suppression. And the 6-mercaptopurine is then metabolized by two other enzymes, principally xanthine oxidase here, and another enzyme called thiopurine methyltransferase down here. And this is inactive, and this is inactive. So these are its principal routes of metabolism to take it away. So what actually happens? Well, TPMT is also a drug, is also an enzyme that's subject to genetic polymorphism, just like CYP2D6. And if you ever wanted to remember a useless fact for quizzes, it's apparently located on chromosome 6. I wouldn't memorize that, guys, because where would anybody ever ask you that? I wouldn't. Anyway, if you have different mutations, different allelic versions of TPMT, you can get a TPMT deficiency. So rather than being overactive, in this case, its alleles can be underactive. And it's been identified there's at least 12 different mutant alleles where, in fact, it becomes effectively inactivated. And the result of that is that you don't break down 6-mercaptopurine. So here, the active metabolite remains in the system for longer in greater quantities because it's not broken down. And if we actually look at the results, then we find that Jim has a mutant allele with extremely low activity. So this increases the risk of myelosuppression. And therefore, if we now jump back to the adult BNF, let's have a look at that. So I'm going to come back to the adult BNF. I'm going to put in azathioprine. So here's azathioprine, and we come down to it, and we see this bit here, pre-treatment screening. Click on that, and it says here, the enzyme thiopurine methyltransferase, and it metabolizes thiopurine drugs. So if you've got reduced activity, then you've got an increased risk of myelosuppression. So these days, and I think, Richard, you use it, you'll probably have used azathioprine in your time, I'm guessing.
Yeah, I've never initiated it, but yeah, as you say, it's now become standard practice that we always measure the TPMT levels before we start it.
So in this case, because you're using it in relatively small number of people, and there's an increased risk of, there's actually a slightly higher prevalence of finding a mutant allele than there was in Emily's case with the CYP2D6. Here, pre-treatment monitoring or pre-treatment screening for TPMT levels is carried out. So one of my daughters actually ended up on azathioprine, and she had TPMT screening before she was commenced on azathioprine. So this is real pharmacogenetics in action, understanding that different people have different responses to drugs. So these are examples of pharmacogenetics, and you'll sometimes come across the two terms. One term is pharmacogenetics, and the other one is pharmacogenomics. And I get very confused when I see these two words, because is there a difference between these? What do you think on the chat stream? Do you think there's a difference between pharmacogenetics and pharmacogenomics? You guys are all very up to date on the genetic stuff. When I did my degree in genetics, molecular genetics hadn't been invented. It was all Mendelian genetics.
In the when I did a BSc, I was taught by a guy who, when he was in his undergraduate degree, they didn't know about DNA. Oh, so,
Gosh.
they didn't know that was the genetic material. So there was still like theories about whether it was protein and stuff like that. So.
I thought for a second there you were going to say he knew Gregor Mendel.
Yeah, not quite at all.
The monk, Gregor Mendel. Yeah. Okay, that's a good answer, Tilwa. Yeah. So guessing genetics is set at birth. Actually, it's your genetic material. And genomics, with the concept of epigenetics, is can potentially be environmentally influenced. I think it's really interesting with the development of epigenetics and the concept that maybe Lamarck was actually not as wrong as people thought he was. It's fascinating and interesting. Yeah, it's different. It's a hard one, isn't it? One way of looking at it is that pharmacogenetics is a single drug gene interaction. So the two we've just described to you there with CYP2D6 and TPMT are single gene interactions. Whereas pharmacogenomics could possibly be thought of as a more wider genomic approach involving elements of epigenetics and maybe multiple genes interacting with each other on the drug response. The reality is, when you read the books, they often get interchanged. The people aren't very good at sticking to strict definitions. But the key thing, I think, in this is to understand that, not everybody responds to drugs the same, both because they don't take them, or take them badly or incorrectly, but also because their actual genetic makeup may influence what actually happened to them. And I suspect we'll also find elements, things like gut microbiome might have an influence as well, potentially. So there may be a lot of different factors. And I think what will happen as you go on in your careers is this concept of pharmacogenetics, pharmacogenomics is going to become increasingly important to the point where you may well find, and they're beginning to do it, I think, with certain types of cancer treatments, is where actually the genetic makeup of the cancer is determining the choice of the anti-cancer drug that's used. And that's, it will also potentially be, I think, with immunological based drugs as well. That will be the case. So I think you'll find a lot more of the situation now that we have the whole genome sequencing, is that we'll actually be doing a blood test and then choosing your drug therapy based on your genomic, your individual genetic or genomic profile. That's what I predict will be happening in the future and through your careers. Not in mine, because mine's nearly at an end, but in your careers going forward for the next 40 or 50 years, that will probably be the situation. Would you agree with that, Richard?
Yeah, definitely. There's lots and lots of research in that area, isn't there? I suppose it's just things are, whole genome sequencing is getting cheaper and cheaper, and it's at the moment still restricted to relatively rare or serious diseases, saying like cancer, but in the future, see where things go.
Absolutely, yeah. So there are these genetic differences, classical genetic differences, but there are other sources of what we would call inter-individual differences in drug action. We've spoken about adherence, compliance, and concordance. We've spoken about pharmacogenetics now, but what about other influences? But there are other things that can happen. Of course, age changes your response to drugs, either being very young or very old. So things like confusion from opioids is more common in the elderly. Absorption can change, and we described a variety of different things. I talked about the gut microbiome, but give somebody diarrhea and they will malabsorb drugs. In neonates, and we'll talk about this next year in year 4 when we talk about child health, but your neonate or your premature neonate has has a normal pH in their stomach. So drug absorption in the stomach in a neonate is different to that in an infant. You've also got issues of different body compositions. So, we have a growing population on average, and that will change body compositions, amount of fat to water in the body. You can also influence metabolism to some extent. And of course, if Richard's a renal doctor, he'll tell you very much what having virtually no kidney function will do to the excretion of water-soluble drugs or renally excreted drugs. So drugs change in their effect. Drugs will accumulate that are renally excreted if you've got poor kidney function. And then, of course, we spoke in the last masterclass about drug-drug interactions, which can either be pharmacodynamic or pharmacokinetic, as well as those issues of compliance and concordance. So it's quite complicated. So I think the message we're trying to get across is don't assume when you prescribe a drug, the effect will always be as predicted. So let's just change tack a little bit now and talk about monitoring drug therapy. And these are some outcomes here. Again, I'm not going to read through them. But what I've, oh, hang on, I have to go backwards. What I've done is I will make sure it's here. I'd forgotten to place it. I've just realized I have forgotten to put this up for you. But I have done an e-learning package on therapeutic drug monitoring, which take about an hour and a half, 2 hours to do. It's quite detailed. I will make sure it's up for you. My apologies, guys. I had completely forgotten when I redid the Ultra courses this year because they have to get everything brand new in. I will make sure it's up, but I have done an e-learning package all about therapeutic drug monitoring, both monitoring for beneficial effects and monitoring for adverse effects. I will do that over lunchtime to make sure it's there for you. Apologies. I just realized when I saw this slide, I've completely forgotten to put it up there. And then we're just going to finish in the last few minutes and go for an early lunch. You'll be pleased to hear about we have to put this in because it's in the outcomes nationally, is understanding some of the ethical and legal aspects of prescribing, which Eleanor and Richard are going to help me with. So I'm hoping. I think the key thing is, Eleanor spoke earlier on about, in the last masterclass, about the effect of thalidomide and the development of the Commission for Safety of Medicines, and ultimately now the Medicines and Healthcare Regulatory Agency, within a legal framework for not allowing anybody just to tell people, here's some snake oil, take this. You've all seen the westerns on movies, haven't you, with the guy selling the snake oil with the really, the sharp guy making money from selling a poison to people, telling him it will cure all ills. So medicines have to be very carefully regulated for safety. So the legal act that covers it all in general is the Medicines Act 1968. And there's a little picture of it there. It's even, it was only £9.10 at that time.
I guess in 1968, that's probably quite a lot of money, actually, wasn't it?
Yes, it would be actually.
Well, of course, remember, this is reprinted in 86, so it's decimalized. It's decimalized at this point. Presume before that it would have been £9 and 1 shilling or something. Be 1971 before decimalization. Ella and I are old enough to remember decimalization. So it provides a licensing system. It creates a marketing environment. It regulates pharmaceutical businesses. It regulates these classifications of what are called pharmacy medicines. These are medicines that can only be supplied by a pharmacy when a pharmacist is present. Medicines that are what we call general sales lists, which are basically, they can be sold in somewhere like a supermarket.
Yeah, that's like the small packs of paracetamol, that type of thing.
And then prescription-only medicines, which can only be prescribed by a licensed prescriber. These days, that isn't just doctors, of course. That could be a licensed nurse prescriber. It could be a pharmacist. It also covers elements of things like homeopathic medicines, herbal remedies. It also covers veterinary drugs and elements around providing information to pharmacopoeias. So you have to define what a drug is. What is a medicinal product? And this is the definition. Please don't memorize it. It's just to show you that behind all of this, we have to have laws to prevent harm to people. So, and this can cover anything from treating and preventing disease right the way through anesthesia to contraception. So when you license a medicinal product, a product license can becomes effectively a marketing authorization. And this also covers things like parallel importing, where you may import from another country or you may import from a generics manufacturer. It also allows you to have things like specials, which are drugs that are produced which are not generally marketed, but are produced for individual groups of patients of very low numbers generally, isn't it, Eleanor?
Yes, that's correct.
And then you've got a wholesale dealer's license, because where does your pharmacy get their medicine from? Well, they get it from a wholesaler. And then you can look at various other elements of important information like the medicines compendium. You get these SPC, the summary of product characteristics. Every drug has to have one of these. It has to also have a data sheet, and these can all be viewed on the medicines.org.uk website. And this is where the information for the BNF comes from as well, most of it. So we often throw around terms such as licensed, unlicensed, and off-label. And this gets I get confused by it.
Yeah, I think some of them are interchangeable, actually, but anyway, yes.
So unlicensed, basically, would it be a medicine which is the whole responsibility of the prescriber? So it might be produced, it might be available, but it's unlicensed, and therefore you can get it basically on a special request, but if you prescribe it for a patient, you as a prescriber carry the whole legal responsibility for the use of that particular unlicensed medication. And then you've got an off-label, and this is generally a licensed drug, but not used for the licensed indication or by the licensed route. So off-label is often what you would be doing in a child.
Yes.
So when you get a license, if I'm going to see if I can bring up the BNF. Let me pull up an example in the BNF of what I mean by this. I'm going to use dalteparin, which is a low molecular weight heparin. And we look at indications and dosage.
So I think you just need to switch over.
Yeah, I'm just looking for a good example, Richard.
Okay.
No, I'm not going to. I'm going to actually use a different one. I'll use.
I'll tell you what's quite good, since we're just talking about it, David. Mercaptopurine.
Okay.
There is a section there, and there's a section on unlicensed use. And I just think it's quite interesting because it was.
I'll come to that one in a second. Let me just show apixaban to begin with. So apixaban, as you guys all know, is a DOAC, directly acting oral anticoagulant. Each of these terms here, see here, prophylaxis for venous thrombolysis following knee replacement surgery. That means they did clinical trials and they have a license. This drug company that makes apixaban has actually put the money and research and effort into gaining a license for this indication. To get the next one for hip surgery, it has to do a whole bunch of clinical trials in people having hip surgery to get the license for hip surgery, because these are all licenses. And then it has to have done studies for treating DVT and PE, as well as providing prophylaxis. So each of these will be supported by multiple clinical trials, these licenses. So these are all licenses. And then you've got this long one here, prophylaxis of stroke, systemic embolism, and non-valvular atrial fibrillation, and at least one risk factor, and then it gives the risk factors. Again, this is based on clinical trial data in both phase 3 studies. So they will have taken thousands of people, and they will have done a big clinical trial at a multinational level to get this license, and it will have cost them millions of pounds to get there. So these are licenses. So if you prescribe to somebody and it fits this, you are prescribing within license. If, however, you were to prescribe to somebody who is outside of this license or any of the other licenses using, say, a Pixaban. So say you gave a Pixaban to a woman with a cerebral venous sinus thrombosis. So that's a venous thromboembolism in a venous sinus thrombosis, often at the back of the brain here. They haven't done clinical trials in that. So it theoretically should work because it's a VTE just like a PE or a DVT, but it's unlicensed. So that would be what we would call an off-label use. So it's using a licensed drug, which is a Pixaban, but not for a licensed indication. Does that make sense to people? And Ellen, you were saying that that's mercaptopurine.
No, it was just interesting. It was more about the unlicensed, but it was just interesting if you go on to mercaptopurine, because it was kind of in context with what we were talking about earlier.
Which bit do you want to go to?
Just mercaptopurine, if you just go under the list of the different options, and there's actually an unlicensed indication.
Unlicensed use.
Yes.
So here it's saying, actually, in general clinical practice, you can use it for ulcerative colitis and Crohn's, but it's not licensed. So this would be...
Yes.
And what's interesting is the BNF here is actually using this probably badly, because actually this is probably off-label. And hence why Elena said often the term unlicensed and off-label are interchanged.
Or off-label and off-license, yeah, they're all...
And a lot of situations in children, we use drugs effectively off-label because we haven't done clinical trials in children.
Could you give the students an example of an unlicensed drug then?
Well, I think the problem is they use these terms interchangeably. So what you're seeing is the BNF is using unlicensed and off-label interchangeably. But strictly speaking, unlicensed means it has no license. So they're suggesting, they're using the combination of unlicensed use versus unlicensed as being different. So they're interplaying unlicensed use as equivalent to off-label. Whereas an unlicensed drug would be one which was like an orphan, what they often call an orphan drug. And you won't find it in the BNF because it's unlicensed.
Hasn't got product license in it.
But it might be for a rare genetic condition supported by individual case reports. And it may be I was trying to think of the example. There's that recent drug, wasn't there? That they just produced one of the biological agents that was being used for rare genetic conditions. But that's technically a truly unlicensed drug.
It's just on your next slide, you've got that 7% of all the drugs given on a pediatric order are unlicensed, but I can't think...
I think that's because the way they count it's mostly off-label, to be honest.
Off license, because the drug is licensed for the indication, but it hasn't been studied in children. So and
that's why I say, in some ways these two terms often get interplayed together.
Yes.
I took this from a publication, and I think it like some of these terms like the pharmacogenetics, pharmacogenomics get used very sloppily, but the key thing is only just over 50% of drugs used in children are actually licensed with a licensed indication. We've got a question there from MR says, if there was a serious adverse drug event, what would be the legal implications for the clinicians if they were prescribing off-label? Very good question, MR. So the answer to that is it would be based on a thing called the Bolam principle. Have you guys heard of Bolam principle? The Bolam principle. Is it principle? Yeah, principle, not principal. Stroke modified by Bolitho. So the original Bolam principle is the principle that said if a doctor can find a group of other medical, now I'm sorry the term is men, people, but it was 1954, I think the original Bolam principle was either 54 or 56 from my memory, was brought in under case law. And Bolam principle said, if you can basically go I think it's the Hackney carriage, and find a group of other medical men who would do the same thing as you, then you're perfectly allowed to do it. It was then subsequently modified by Bolitho about 15 years later. And what Bolitho, the case from Bolitho, where was that actually that group of medical professionals, because this by the time we moved away from just being medical men, thankfully, had to be providing a reasonable action. So the judge has to determine whether this group of medical professionals are within what one might call the central core of medical practice. So it's now Boland principle modified by Bolitho. So basically, if you can find 2 or 3 other people who'll do the same as you, and they're worthy people and are not extreme outliers of normal clinical practice, then you're protected from litigation. So, and a good example would be that one there with mercaptopurine. We go back to the BNF and we look at that bit, it says unlicensed use. We've actually says in the if it actually says that in the BNF, that tells you that it's a perfectly legitimate use. Now you may argue, why is it not licensed? Well, the drug company isn't going to spend a couple of £1 million doing the clinical trials to get the license. It's not value for money for them. But there's plenty of case reports and other published studies which would support its use in that scenario, and hence you're protected under the Boland principle. Whereas if you were to, for instance, under Boland principle modified by Bolitho, were to find some extreme clinician in the hinterland of goodness knows what foreign country who did the same as you, that wouldn't be covered by Bolitho, because that would not be regarded as being a reasonable other health professional potentially. So that's where the modified by Bolitho came on. You couldn't just go and find a couple of extremists who believe the same wacky ideas as you and therefore get protected from litigation. Does that make sense? Richard, any comments on that? I'm paraphrasing my master's in medical law.
Yeah, and it's just, I suppose, different clinicians have a very different, or at least different departments and hospitals have different like acceptance of risk around that, don't they? So that you will get departments which have made a decision as a group to use a drug off, well, I was going to say off license, but off label. Yeah. So for example, a classic one for us is in kidney medicine is using apixaban in people with end-stage kidney disease, which it doesn't have a license for, but is widely done, especially in the US. And but then other departments will decide, no, we're not going to do that. Even though I suppose, as you say, they'd be protected in doing that by this principle. The decision is still made that that's not what they're going to do as a department.
I mean, it protects you from a negligence claim. It wouldn't necessarily protect, it depends, of course, on everything else having been done appropriately. Because what's interesting, you could also be, say you did do that off-label use, if you hadn't fully explained to the patient and sought some form of consent, usually verbal consent, and documented your discussion with the patient, you can actually still be done for negligence for negligence because you failed to consent the patient. So there is also a clause under law of negligence by failure of consent. So even though actually what you did was a reasonable thing to do, if you didn't explain it to the patient and didn't explain the adverse outcomes of doing it, and therefore they didn't have an ability to choose not to have it done, then actually you can be also done for negligence under failure to consent. So actually it's a little bit more complicated. You know, if you're going to be using a drug off label, it's very important you explain to the patient about the fact that it is actually off label, but that other people use it, and this is why I'm going to use it. And the patient could then turn around and say, well, if it's not licensed, if it's off label, I don't want it. And that would be perfectly within their right. But if they're not given that option and you harm them, although you might be protected by Boland from negligence, you might still be subject to negligence by failure to consent. Although those are actually quite difficult to prove under law, unfortunately. But it can happen. It's usually failure to consent for surgical procedures. To be fair, that's most common that it's found under law. Right, we're nearly done, guys, and we've got about a couple of minutes left. So we spoke a bit about this earlier on, the difference between general sales list, which is things like this up here, which can be bought openly in any shop, really. Pharmacy-only medicines, which are medicines which you can only buy across the counter in a pharmacy when the pharmacist is present. And you may well find that the pharmacy technician will ask you a bit more information about your health before agreeing, and then they go quickly to speak to the pharmacist, and the pharmacist, yes, you can sell that. Prescription-only medicines require a legal prescription from a registered prescriber, and controlled drugs have other elements of recording and dispensing requirements, including elements of how the prescription is written. Important one being that things like the dosage has to be written in both letters, as in words and figures. So if you wrote 50 milligrams, you'd have to write 50 milligrams.
No, you can do that, David. It's the total quantity required has to be in words.
Yeah. So 50 milligrams, and you wanted, say, 30 tablets. Then you'd have to write 30 tablets as well, wouldn't you?
Yeah.
Oh, can't spell.
And they reject it if you write. So if you wrote tablets instead of capsules or something like that, then that would be rejected.
Yeah. But the reason why that was introduced was to prevent people doing things like, an example would be, instead of it being 30, it's been, and this is particularly when it was written, maybe it was supposed to be 15. And then what happens is the person who's got the prescription takes it home and decides, actually, I quite like taking this opiate. So I'm just going to add a 0 at the end, and now it's 150 tablets. So now I've got 3 times as much, and I can sell some of it on the street. So this bit was introduced to prevent people fraudulently changing their prescriptions. And also subsequent to the shipment, there was a big thing about Harold Shipman, who was convicted of murdering patients with giving them excess opiates. These days, there is very close monitoring of opiate prescribing in the community. So all opiate prescriptions are separately reviewed to monitor opiate prescribing by individual practitioners. Subsequent to the Harold Shipman affair, and it came out of one of the 4 reports from the Shipman inquiry. So this is an example of a printed, or would be a printed FP10. It's got a specimen across it because you don't want to actually have one of these floating around without that, because in case somebody creates a fraudulent prescription. But basically, these are called an FP10, and that's for GPs to use. And it will have different codes on it. And SS means it's computer generated, NC is handwritten. If it's a dentist that's issuing one, it has a D on it to indicate dentist. If it's one that's being used for substance misuse under Section 2 of the Dangerous Drugs Act, then it has to have additional coding on it. In hospital, we can issue community prescriptions, for instance, on a Sunday night to save somebody staying in hospital because there's no pharmacist present. In something like an ED or an acute medicine or surgery unit, a fully registered practitioner, it cannot be an F1, can fill out an FP10 HNC so that the person could take it to a late night pharmacy and get that drug upon discharge. Interestingly, in hospital, the drug charts that we write on, or the electronic drug prescribing systems that we now prescribe into on computers, are actually under law, not technically prescriptions. We all call them prescriptions, but under law, they're not actually prescriptions. They are technically what we call a written order. And this is what allows F1s to prescribe in hospitals. And they are written orders and records of administration. To actually fully do a legal prescription, you have to be fully registered as a doctor. And that's why F1s can't issue FP10s, or they can do immediate discharge letters because that's technically still a written order because it goes to the pharmacy as a written order for dispensing. That's the correct way to describe it, isn't it, Eleanor?
Yes.
But we all call them prescriptions. But your F1 couldn't walk out to a local pharmacy and fill a private prescription for somebody. Whereas a fully registered practitioner these days can still walk into a pharmacy and say, I want to issue a private prescription. And as long as they do it in a legal way, they can just write it on any bit of paper, any piece of paper, and the pharmacist, if they agree to dispense it, they will check identities, they will check the GMC record, and they can actually then dispense that. Although the GMC, you need to be aware, has issued quite rigorous guidelines suggesting what is appropriate, particularly for self-treatment or for treating members of your family. So you would have to adhere to that because, there is clear evidence that people, when they treat themselves or own family, are not necessarily making often the correct decisions because of unconscious biases. So, the ability to go and do this is much less these days. It used to be quite a lot of doctors would go and, for instance, get antibiotics to take on holiday with them. You try and do that these days, and a lot of pharmacists will refuse to issue it. Interestingly, virtually all the drugs in a GP's bag are generated by doing private prescriptions. But the pharmacists know the GPs and understand that that's how they get the morphine for carrying around with them. It's how they get their benzyl penicillin for immediate treatment of meningitis. They effectively write, I believe, private prescriptions. That's correct, isn't it, Eleanor? But they're then dispensed so that the doctor can carry those medicines for emergencies in their doctor's bag. So here's an example of, in this case, this is a morphine prescription. And you can see here how we've written both 56 in words and numbers for the capsules. So there's no chance somebody could change that to 560. So you can't change it. And it all has to be capitalized and it has to be written in words. So it's more difficult to fraudulently alter. These days, most often these, of course, in GPs would all be printed off the computer system. But to make it a legal prescription, it's got to be signed, must be indelible. You must have the address of the practitioner, so you've got to have the address down there. If you do a private prescription, you have to do the same thing. It must indicate the role of the practitioner. So if you sign here, you must put down what your role is. You must date it. And you must have the full name and address and identifiers for the patient, including things like age or date of birth, particularly if it's somebody who's a child. The other thing just to cover here, which is these abbreviations that you will come across in clinical practice. These are abbreviations based on Latin terms. We would always encourage you to not use these. I think why in the modern era, we're in the 21st century now, why are we using abbreviations of Latin words? So, for instance, you will often see OD written, which actually stands for Omne Die, which is every day in Latin. So why don't we just write daily? Or once a day on a form? It's so much easier. PRN you'll often come across as a very frequently used abbreviation. It actually stands for pro re nata, which I believe in Latin. I mean, I did Latin many years ago and I was very bad at it, but I understand it means when required.
Mm.
So why don't we just write as required or when required instead of PRN? Stat is often used because people watch too much American television, and everything in ER is given stat. Timo's asked an interesting question there, hasn't it? Is it because of language? People in other Latin-speaking countries have the same nomenclature. I don't think it's the reason for that. I think this is a hangover from when doctors used to speak in Latin as a way of mystifying medicine and preventing anybody else from being quack practitioners. And I think this is just a hangover.
Mm.
Yeah, because I guess once the medication is dispensed, it's going to say once daily, twice daily, or whatever. So it's not as if it's going to help anyone if they go abroad or anything like that. It's literally just a prescription, isn't it? So.
Yeah. So I think our view has been for a while now, you should use plain language wherever possible. And if you look at something like the prescribing safety assessment, that exam you sit in year 5, everything in that will be in plain language. It does not use any of this abbreviation. And I don't believe these abbreviations are in electronic prescribing systems either.
I think it depends on the electronic prescribing system. Yeah, I think I'm pretty sure the one they have in Doncaster does have OD, TDS, all that stuff.
Well, it should be erased.
Yeah.
I mean, why build that into a computer program? In this modern era, plain language. So I think you should use these. I'm not even going to try and pronounce QQH. I've never used QQH. Quatra quaque hora. Why not just write 4 hourly?
Every 4 hours
or 4 hourly. Yeah. Don't use them, guys. Don't use them. But it's just interesting. And as the stat stands for statin, which is immediately. And people use this. I just love this. Walking in and trying to play like you're in Grey's Anatomy or something and go, I want it stat. And the nurses look at you and think you've got 2 heads. Yeah, which is about the properly way they should look at you if you use the word stat in clinical practice. My opinion. Right, the good news is we will cover a lot more prescribing in detail in year 5. It's now 12:30. I think it's time for lunch. We are going to come back at, oh gosh, let me just double check. When are we coming back? I think it's 1:30. 1 sec, guys, while I just double check that. Yes, 1:30. So we've got just under an hour to have lunch, which is good. So I'm going to suggest we stop there. Again, if you have any questions, do ask them. Delighted to take any emails at any point from you with any questions, any feedback, very welcome indeed. And we will see you for block 34, masterclass 3 at 1:30.
Can I just mention, because I've been looking in the background, trying to answer Richard's question about examples of unlicensed. I've found potentially 3. Some of them are actually in the BNF, which is interesting. So melatonin is one. For short-term insomnia. Diltiazem cream, which is used for anal fissures.
Right.
And midridine. I don't know whether you've ever used that.
Right.
Yeah, use that a lot.
Yeah.
That's actually that's a non-UK import. It's imported from the States, I think, because it's licensed in the States. But the melatonin and the diltiazem are what we call specials, which you mentioned at the beginning about the different licenses that they. But I'm sure there's others that are completely unlicensed. But that's 3 that I've come up with.
Interesting. Yeah, that's interesting. Right.
I bet most people who use midodrine don't realise it's completely unlicensed, and that all the responsibility will go on them if anything goes wrong. That's
Yeah.
Definitely something for the people to be aware
Where
of.
does it say unlicensed, Eleanor, for Midradine?
That's just what I found just looking around, but I don't know if it says it in the BNF.
It doesn't say in the BNF as far as I can see.
Mm.
Interesting. And what was the other one? It was
Diltiazem cream, which is definitely not in the BNF.
Diltiazem. Let's have a look. And it's not in the BNF.
No, that's the cream.
Medicinal forms.
That's the specials. Mm.
Right, yeah, it doesn't have that there. Yeah.
Mm. Mm.
Yes, it's only got tablets or capsules.
Mm.
That's interesting.
Yeah, it is interesting.
Mm.
Yeah.
Okay, guys,
They've
all. I think they've all gone for lunch, Eleanor.
I think
Well
so.
Yeah.
So
Don't blame them.
I think we'll stop there.
Okay.